So we have an amazing collection of people here this morning. Looking around the room, I see eminent scientists from across the country, home mentors. We have our K12 scholars. We have cohorts 2, 3, and 4. And we even have somebody from cohort 1 who came back because she's part of the family. Looking around, we see people with lived experience. We have patients that are here. We have clinicians. We have patients and clinicians in the same room, and it's not an exam room. We have program officers from NIH. Looking around, we also have directors of the K12 program. We have the staff of the K12 program who have worked tirelessly over the last few months to make sure that this conference comes off smoothly and to make sure that our persons with lived experience are accommodated and so that everybody can enjoy the conference. That was for you, Tom. You may also have noticed that we have not one, but 2 film crews. One film crew is filming the proceedings that's going on this week. The second film crew is filming a curriculum that has been co-developed by our PWLE and our K12 scholars on how to engage PWLE in research across the life cycle of studies. And that curriculum is a curriculum that all of our K12 scholars have participated in and now have helped to develop and expand. But we wanted to get it on film so that we'd be able to share it beyond the K12 with T32 programs and T90, R90 programs, and really any clinician who might be wanting to do a research project with the involvement and engagement of PWLE. So it's going to be on durable media, and it will be out there for anyone to access. So that's going on this week. So if you're up here and you're talking and you see people leaving, they're not being rude, they're advancing science. The filming is just down the hall. Over the weekend, the cohort 4 scholars were matched with their scientific mentor and their PWLE mentor. So this is a great opportunity. If you haven't been able to meet in person, meet up with your mentors. The mentors will have an orientation after the ICON conference next week or the week following. We offer this orientation and kind of, every mentor has engaged in mentoring, but maybe not in the context of the K12. And so we will be having an onboarding session, and that's going to be with the directors of the program, and Laura Wander is going to be participating in that onboarding as well. So on to the agenda for this morning. K12 scholars meet with their mentoring team, which is comprised of their home mentor, their scientific mentor, their PWLE mentor, and any advisors that may be part of their mentoring team. Quarterly, so 4 times a year. And those are usually relatively small meetings that are working meetings where you get everybody on board with what you're doing, you solve problems, you work through any issues that may be going on in your career trajectory or your project. However, once a year in the summer quarter, we have a chance to expand that, and everybody gets to attend that quarterly meeting. And so the K12 scholars are able to present their work so that everybody is on board with their progress. And that's what we're doing today. So we have 3 groups of scholars that will be talking with us today. The first group is going to be our cohort 4. These are the brand new scholars. So this is really just kind of a chance to get to know them and what their projects are about and what their trajectories are about. Those will be the first presentations. We'll take a little break, and then after that, we have our cohort 3 scholars. These are folks who are now been through 1 year and they're embarking on their second year of the K12 program, and they'll be talking with us up until lunch. And then we'll have lunch, and then right after lunch, then we'll have our second year cohort. And these are folks who are starting their third and final year of the K12 program. These presentations are going to be a little bit longer because they've been with us longer. And we'll have a chance to hear about their progress and their next steps after the K12. So that's the agenda for today. Please do ask questions in between. We have a microphone over here, and I can kind of bring it around. Because we are filming, it is helpful if you use the microphone for your comments so that we can capture your question. The podium is up here. When it's your time, you have the agenda. When it's your time to come up and talk, just wait for the person in front of you to finish and then come up and either plug in your slides, or if you've given your slides to Sarah in advance, then she can assist with that, or it should be loaded on as well. So let's get started. Our first presentation will be from our cohort 4, and this is Sydney Axson.
Okay, good morning, everybody. I'm Sydney Axson. I'm an assistant professor in the College of Nursing at Penn State University, and I have a joint appointment at the university's Rock Ethics Institute, which is part of the College of Liberal Arts. I say my work is at the intersection of nursing, health services, and bioethics, which is a bit of a busy intersection, and sometimes I throw even more in there. But I'll share a little bit more about me and how I'm trying to carve a space out in my science. So I was a little bit of a late bloomer academically. I was a rower in college and wanted to take rowing as far as I could go. But it was through my political science major that I was introduced to philosophy and ethics, and ultimately bioethics. And when I found my interest in bioethics, that's what motivated me to want to learn more and pursue a graduate degree. So after Syracuse, I moved to Philly. I did move to Philly to row at the elite level. That's a picture of Boathouse Row. It's a big training hub for the US women. And I did that for about 10 years. Gave me a lot of cool experience, a lot of cool races. I got to represent my country, but I knew that it was never going to be a career. So when I moved to Philly, I also enrolled in the MPH program at Penn. And my thesis focused on informed consent. And informed consent is still a big part of my research. It's about half of my research program. So I'm happy to talk about that. I'm not going to talk about here, but just want people to know that I also do bioethics. So being on Penn's campus, I learned about the BSN to PhD program, and it seemed perfect for me. Being a late bloomer, I thought I missed my opportunity to be in health. So this kind of opened up a lot of doors for me, and I knew I wanted to do research, so it was the perfect path. I started out doing projects related to public health and harm reduction, particularly around Narcan. And then I eventually focused in on adolescents and young adults, opioid prescribing and non-medical use of prescription drugs. But really, as time went on, particularly in the last couple years, and as my time working as a bedside nurse on the neurosurgery floor, I just kept seeing pain come up over and over again. And I felt like I needed more training to really bring that into my science in a way that is clinically meaningful and rigorous. So I sought out a postdoc. I was in the National Clinician Scholar Program at Yale. Michigan also has that program. And this had a health policy and health services research focus. I was hoping to kind of dig deeper into pain, but as many also probably experienced, COVID really disrupted how I thought this training would go. Yale closed like 4 days after I arrived. I really pushed myself to leave Philly, where I had been for 10 years, to grow and build my network. And then I moved to New Haven and I met nobody. But the silver lining was I did have to pivot to use existing data again to keep my research and training moving forward. And I found that I really quite enjoyed using existing data and more advanced, at least advanced to me, statistical methods. I really leaned into doing so as a way to leverage existing data to its fullest extent, reduce participant burden, and better identify what data really needs to be collected prospectively. I worked at the VA there. I got to work with their nationwide EHR data set, which had nearly 300,000 records in my study. And I got to learn some longitudinal analyses, which was really cool and new for me. So very useful, even though it was a little bit unplanned. So I've been kind of circling pain science and moving towards it for a few years, trying to find a way in. And so I felt very lucky when I saw the K12 call in my inbox. I felt this could really, provide the time and space needed to build the skills and community I need to do this kind of research that, again, is clinically meaningful and patient-centered. And really the biggest draw for me was to join and build community with mentors, other junior researchers, senior researchers, people with lived experience, all the people who are working to improve pain and outcomes. I wanted to be a part of that. So I know my project is going to change, so I'm not going to talk about it too much, except that this is what I've proposed, and I know it's going to change. But this is really to say that I am interested in adolescents and young adults and the treatment of both chronic pain and substance use, and then the relationship between those two conditions. I'm aiming to grow my skill and expertise in pain science and statistics to move towards causal inference. And at the end of this, I am hoping that I can prepare a competitive R proposal that will leverage observational data for causal inference, particularly with more vulnerable populations like young people who use substances or conditions that cannot ethically or feasibly be studied with the traditional randomized design. And this is just me in a nutshell. I always said after I was done rowing, I would get a dog. So I did that. My last competitive race was the Royal Henley Regatta. So I named her Henley. She's known around the neighborhood as Stick Dog. I still row. I'm recovering from a back injury, but I row for fun now. That's why I live in Philadelphia and not closer to Penn State's campus. And that's me. It's nice meeting everybody.
Hi, great to hear. This is not a question, it's a comment, but in service to you, in my other life as an NINDS and not HEAL program officer, NINDS has a strong interest in bioethics. We have a highlighted topic on it. We have a program officer dedicated to it. So I'm happy to connect on that.
Okay, yeah, definitely.
To nurture that part of your scientific life as well.
Yes, great, thank you.
Going back to your research into AYAs, is that specifically for non-cancer patients or?
Oh, yes, I meant to say that.
Okay.
Non-cancer chronic pain.
Non-cancer chronic pain.
Yes.
Okay, thank you.
From the population set that you currently study, what overlapping themes do you notice?
In regard to?
Both adolescents and adults with chronic pain and possible addiction?
Yeah, so I'm in this program largely to bring in that chronic pain, but so far there has been kind of a high co-occurrence when I look at young people who use, let's say, their prescription opioids non-medically. There does seem to be a high occurrence of pain. And that's actually why I say non-medical use instead of misuse or abuse, because misuse according to who, if they're managing pain, for example. There appears to be a link to me, but when I look at the literature, this is a little bit of an understudied population, at least when it comes to non-cancer pain. So hopefully next year I will have a more clear answer for you.
That answer was great because as someone that does live with pain, that is something that we try to explain to our healthcare providers. So I really love that you're researching this in general, especially because I was an adolescent trying to navigate this as well. So great job.
Oh, thank you. And I'd love to hear more. Thank you.
My name's Tom. I'm a PWLE. My question is, well, actually, it's a comment. If you wind up needing more young adults for the study, I've got a support group that would fit because there is opioid use in that group for pain management, and they're using it just because it works.
Yeah. Oh, that would be great. So
All
I'd
right.
love to talk to you after.
You got my number.
Thank you so much.
Thank you.
Okay, thank you.
Thank you, everybody. Thank you.
Okay, next up. Yeah.
Oh, sorry.
So hi everyone, my name is Chiyoung Lee. I'm assistant professor from the College of Nursing, the University of Arizona Health Sciences. And the picture is actually the beautiful building of College of Nursing at the U of A. So I've been working as an assistant professor since 2024 at the University of Arizona, U of A, the Tucson campus. And so this is my third year. I just submitted my third year review last week. And so the most of the faculty, yeah, thank you. So the most of the faculties and the researchers at College of Nursing U of A study about the cancer, mostly about the cancer and also the pain, especially focusing on the symptom science and intervention. And we clinically partner with the Banner University Medical Center at Tucson, and we do have a really collaborative culture across nursing, medicine, pharmacy, and also the public health, and also with the Arizona Arthritis Center at the U of A. So my background, so I have received my bachelor. I'm a nurse, and I have received a bachelor in science, Bachelor of Science in Nursing, and Bachelor of the Masters in Nursing at Seoul National University in Seoul, South Korea. And while back in Seoul, I have worked as a clinical nurse at 4 years at the Samsung Medical Center, the Galaxy, the phone Samsung. And I work at the intensive cardiac care unit for 4 years. And also after graduating from the Masters in Nursing, I have worked as a clinical faculty for a year at the Seoul National University Hospital. And then I came to United States in 2017 to continue my study for a doctorate degree, and I got a PhD at Duke University College of Nursing, School of Nursing. And after that, I have been as an assistant professor at one of the satellite campuses of the University of Washington, and I mostly study and teach about the statistics. And so in 2024, I was really fortunate to get a job at the U of A. So I would say through the 2024, my research has actually most focused on the statistics, especially around the methodology development that applies statistics and teaches statistics to the not only nursing but also the health science people in the symptom research area, including the pain. And after I got a job at the U of A, I was really, really fortunate to meet my great mentor, Dr. Ken Ko, who cannot join today, but I met him and started to study about the knee osteoarthritis pain. And we actually really meet once in a week over like 2 years. And he taught me really a lot of great topics around the knee osteoarthritis pain research area, including the central pain mechanisms underlying knee pain, chronic widespread pain in knee osteoarthritis, which has not been studied that a while. And also we have studied about the home-based neuromodulation, brain neuromodulation for improving the knee osteoarthritis pain for 2 years. And I would say my career goal would be to build the interventions that are not mildly effective on average, but effective for the right person at the right time. So, Dr. Cohen, my research question has always focused on the who benefits the most. And that's why we study around the concept of heterogeneity of the treatment effect of home-based brain neuromodulation for the knee OA pain. And we have studied about two groups of the patient within the knee OA patient. The first phenotype is the people who have a knee pain, but that is no longer local because we think that many old adults with the knee OA also carry the chronic widespread pain. And when the pain is spread beyond the joint, does a locally recent intervention still work? That was our research question over many years. And also the other group that we have focused on is the for patient whose physical pain carries together with the cognitive and emotional symptoms of the pain, including the pain catastrophizing and depression and disturbed sleep. And we're thinking about which combination of stimulation exercise is most effective. So mostly about, we are thinking about from, does the intervention work from whom and under what conditions, and does it work? So this has been me and Dr. Ko's research for 2.5 years by now at the U of A. So for the proposed NIH K12, I will not go into the details, but the idea has been really evolved, and that this will be changed, but it will be around when does my intervention work? And it's under the concept of circadian-informed brain neuromodulation for improving the knee OA pain. So Dr. Ko and I have came across the article that's called the influence of circadian rhythms on TDCS, the transcranial direct current stimulation, one of the brain neuromodulation technique that our lab is doing, effects. And this is basically saying that there is an optimal window that brain neuromodulation has to be done, where the sleep pressure is really low and then the cortical excitability is high at the peak. So we are thinking about, and this study has not been done yet in the field, so we are really studying about it really deeply and trying to come up with the aims in a meaningful way. So basically, in summary, we're thinking about aligning our intervention to individual circadian phase rather than to convenience may itself be a determinant of an analytic response. So what drew me to the HEAL K12 program? I really want to be in a pain science community that I do not have yet, so because I do want to meet with the great mentors and also make many friends, and also really grateful to have a PWLE partners with me, and I really want to learn the pain science properly from the beginning. And yes, I also really want to make a lot of friends here. And who am I out of science? I'm a mother of 3 daughters, including the cat, Rosie, and also the dog, Leia, and also the human, Hajin. And she just celebrated her birthday, and we celebrate her birthday, the first year birthday, back in Korea and just came back. And my husband, Brian, always joking that if we give another birth of another female, the daughter, then the next step would be him adopting the male cat and dog. All right, so thank you for listening to my presentation.
Thank you for the very nice presentation and welcome to the team. How are you planning to do the cortical neurostimulation? And are you gonna, I saw your presentation includes glutamatergic and GABAergic. Do you expect to see more glutamate response or GABA response?
Sorry, can you say that again? Sorry, I didn't.
Yeah, first, how are you planning to do the cortical neurostimulation? I'm sorry if I missed that. And the other thing is, do you think you would expect to see more glutamate response or GABA response?
So the first answer would be, so our lab has been doing a lot of brain stimulation called the transcranial direct current stimulation, TDCS, for a while. So we're going to use that as a home-based approach. And then your second question, I'm studying about those. And then I do not really have an answer yet, but yeah, I'll have an answer maybe later on. Get back to you. Thank you.
Thank Great presentation. Again, my name is Tom. I'm just wondering, what kind of pain scale are you going to use? Are you using the 0 to 10, or are you using the quality of life scale?
So right now in my study, we do have a lot of pain scales, not only the numeric rating scale, but also the scales that are specific to the neosteroiditis. Yes, and then we are trying to adopt many comprehensive pain scales for our patients so that we can examine, we can assess in a more comprehensive way.
If I could recommend,
Yeah.
try the quality of life pain scale that was developed
Okay.
37 years ago, and it talks about, it's from the patient's viewpoint of what they can actually accomplish. I think it gives a more realistic picture of the pain from a PWLE perspective.
All right. Thank you so much for the
Thank you.
recommendation. Thank you.
Make sure that we introduce you to Ruby Lee, who's one of our Team MD fellows, and she actually is quite expert in circadian rhythm. She first began in Woodley, but this is really an interesting hypothesis that stimulating at different parts of the circadian rhythm would have different effects. So make sure you meet Ruby and talk to her about that.
Yes. Thank you.
Okay, thank you very much.
Thank you.
All right, good morning, everyone. I'm Olufunke Martin. I go by Funke, and I'm an assistant professor of pediatrics, a pediatric hematologist oncologist at UT Southwestern Children's Dallas. I'm really excited to be here talking to you all. To know me is to know that I love to live life in motion. When I'm not doing medicine, I love to travel, specifically internationally. I love to experience other cultures, food, and then I think one of my greatest joys in the top right is my now 2-year-old who is starting to join me on my adventures. So that is to know what I spend my time outside of medicine. But a little bit about my background. I did training all over the United States, but started at Michigan State College of Human Medicine, which was kind of the first time that I got exposed to research. I always knew I wanted to be a sickle cell researcher, but wanted to be a sickle cell doctor, but thinking about research really didn't come to kind of the front of mind until I went to medical school and really kind of looked at the patient from a clinical perspective, but then wanted to think about what could I do from a research perspective to make change. And then I did my residency at Riley Hospital for Children in Indianapolis, where I really spent a lot of time looking at the management of pain for pediatric kids with sickle cell disease in the emergency department, as well as looking at provider understanding. And then from there, I did my pediatric hematology oncology fellowship at Children's National Hospital in Washington, D.C., and did some work with like large databases, but then also kind of started to figure and wonder, how could I make that link to the underlying pathophysiology of the disease? So what is going on from like a mechanism that's really driving the pain experience? And so that's kind of set the stage for where I am currently, which is at UT Southwestern as a clinical translational investigator. And I would say that my overall career objective is really focusing on how we can shift pediatric sickle cell disease care from being reactive to proactive, with the ultimate goal of being an independent NIH-funded investigator, but really strengthening that bi-directional translation between what I see clinically and what some of the mechanistic laboratory models for sickle cell pain say. And I often hear that in pediatrics, it's the very vulnerable time to really kind of affect change, but I feel like we're often reactive. So we focus on healthcare utilization metrics, we focus on like single pain time points, and then oftentimes, you know, we wait and then someone develops chronic pain and then we say we don't really have very many options for you. And so my vision is really moving towards something more proactive and predictive in our vulnerable pediatric population by really kind of looking at one of those mechanisms, adhesion or stickiness of the red blood cells, and trying to couple that with what the patient experiences and what they report about their daily function, and seeing if we can identify high-risk individuals early and be able to intervene and hopefully prevent pain progression. And so my research objectives are really about defining pediatric sickle cell disease pain phenotypes using adhesion as kind of an anchor mechanistically, and then looking at that longitudinally over time to see if there's a correlation between pain experience and these biomarkers, and then hopefully being able to scale this up in a multi-center fashion. And then from a career development standpoint, really just wanting to build expertise in mechanistic pain science, biomarker implementation, and really some predictive modeling, and then advancing patient-centered sickle cell pain research, and then ultimately, hopefully, being able to transition to competitive K or R level funding in the next phase of my career. For this K12 project, I'm really excited to kind of be thinking about that biologic anchor, specifically looking at vascular adhesion biomarkers or stickiness of an individual's blood. It's something that can be compared against other individuals that are kids, but also within the individual. And so my hypothesis is that those individuals with high stickiness are more likely to experience higher pain burden. And I collaborate with a lab actually here in Michigan that does these cool assays that you see at the top right. And without getting into all the details, my hope is that with the K12, being able to kind of define and track over time the adhesion and pain experience for kids with sickle cell disease, that I'll hopefully be able to build more of a biomarker-informed risk stratification profile for pediatric sickle cell pain. And really excited to be a part of the HEAL K12 program. Talked a little bit about the foundation that got me here, but I really feel like the HEAL K12 is that bridge. And it's that bridge that provides the protected time that is so unique to be able to actually do the research, the multidisciplinary mentorship, specifically building expertise in pain science, neurobiology, and then vascular adhesion translation, and then getting some more advanced training in repeated measures and predictive modeling. And then I really love that aspect of the PWLE. I have personal family experiences with sickle cell disease, but I've never actually incorporated it through the lens of a collaborator in research. So I'm really excited about that part. And so yeah, thank you all.
Hi. So you shared that you have family members that have experiences with sickle cell, but I also want to know what inspired you to research the specific parameters, and do you have any experience with researching populations using hydroxyurea?
So yeah, I mean, earliest memories being a teenager, going with family members to visits is really what prompted me on this pathway. And I think picking the specific parameters that I did, it just came naturally through the evolution of my training and having mentors that were doing some work in this area, and finding it as an interest. Again, seeing the pain, I think clinically, you get a lot of exposure to kids in the hospital. So pain is one of those most pervasive things that you see. And so thinking every time, like, what is something that we could do to maybe understand who's at risk earlier? And so when the opportunity came to partner with this lab, I just kind of jumped on it. And they had done a lot of work in adults, but not specifically in kids. So that's where I've kind of developing a niche. Thank you.
Hi, my question is that your age range is 8 to 18. How, when you're asking these questions about pain management, do you see that might be different when you're asking an 8-year-old as opposed to a 15-year-old?
Yeah, I think that's a very fair question. One of the main surveys that we use is Promise Pain Interference in my survey. And then I have a whole host of battery of surveys that I use, some that unfortunately target the parent in the younger age groups versus actually asking the young adult. So trying to balance it both.
How are you looking at other psychosocial factors that elevate risk for development of chronic pain and how that might confound or be associated with what you're targeting, the research you're targeting?
Yeah. I think it's a great question, one that I've kind of struggled with a little bit as well. What we settled on for my study was looking at area deprivation index, which I know is not a perfect way, but a way to kind of capture neighborhood disadvantage. I've used that in some other studies where we had seen some disparities just in terms of accessing curative therapies. So that's what I have now. But again, I'm really excited to see how this is going to evolve. But I don't have like a strong focus outside of using ADI scores.
This is a question that's down on the grass, so forgive me. I'm interested in finding out how you're planning to integrate parents into your study. You're working from 8 to 18, so parents are be involved in most of it. Talk about, if you would, how they perceive the pain, because I think they're going to be the first ones to talk about it.
Yeah, I think I was intentional in this study about really wanting to get the patient's report, unless it was a young child, in which we would lean on the parent. And I think that is, as a clinician, also seeing that sometimes we often look too much to the parents in some ways, that we don't let the kid have the voice to kind of explain their pain experience. So my challenge with this is really getting the kid to think about their pain experience and getting that report and seeing how that correlates with their biology.
Thank you so much. Tom, thank you so much. I love this conversation. This is amazing. I'm up here like talking to Kadeem and I'm like, oh my gosh, this is so awesome. My name is Todd. I have sickle beta thalassemia plus, and this, to that specific point, 8 to 18 is a very transformative time for an individual with sickle cell. And with working in sickle cell as a community health worker and also as a researcher, you can see how much you can have helicopter parents or parents that care so much for their kid that they actually are inhibiting their independence, their ability to care for themselves and advocate for themselves in a way that will benefit them throughout their whole lives. So being able to have them be more independent and hearing from the actual patient, the actual warrior themselves, is super important. I love the fact that you're looking at preventative measures. You're looking at, what we can do before we're actually there, because as a, sickle cell isn't something you see. A lot of individuals with sickle cell will come and present in the ER, and there will also be someone in the ER that, has blood coming off of them. But we also have the, risk of stroke, acute chest, a lot of these life-threatening factors or symptoms that could potentially, keep us in the hospital much, much longer, but we're not seen as, not important, but as risk, as urgent, right? So it's very amazing that we're seeing the use of biomarkers and preventative measures versus, the use of opioids or anything else like that. So I just wanted to give you your flowers on that. This is awesome. I can't wait to see more on that. And then also, because I just remembered, peer health coaching. I think that would be amazing to use within this type of work to see how, you can get vulnerability within the participants that might have reluctance with research in general. So I'd love to talk more. Thank you.
Yeah, definitely. Thank you all.
Hello, everybody. I'm Shaddy Saba. I am an assistant professor at the New York University Silver School of Social Work. Been really cool to hear about my new colleagues' research. I'm excited to get to know all of you more. So outside of work, my wife and I moved to New York City for my job. It feels recent, but time is flying. I mean, it's been almost 2 years, but I feel pretty new there. And so hence the pigeon statue photo. We also have one child named Baby Belle. She's a nice cat. Really enjoy kayaking, which we lived in Seattle prior to New York City, and trying to find kayaking that's as cool as it is there. I like things like live music and sci-fi, learning Spanish. I tried to think a little bit more broadly than like walking around and eating, because that's the primary thing that I do. But so my pathway to pain research, I'm a clinical social worker. I got a master's degree in social work from the University of Chicago. So worked as a social work clinician for a few years before returning to academia. And one of my, kind of formative experiences was working in a chronic pain clinic at the University of Pittsburgh Medical Center, where, I trained to deliver psychosocial treatments for pain, things like CBT and ACT, and motivational interviewing. And, worked with a big interdisciplinary team as well, physicians, nurses, PT, OT, which was really great. One of the things that I saw in clinic was that, we had treatments that like on paper were for, behavioral health aspects of pain. But when people had, complex, like multiple challenges at once, it became kind of more difficult to provide something that was useful for people, right? And also like the importance of life stages. So as people were transitioning, working with emerging adults who were, trying to navigate life changes and think about, what they wanted out of life while also navigating a health challenge. So that really inspired me to get, academic training to work to improve the field, right, in different ways. And so I did a PhD at USC, also in social work, with my advisors there, focused on behavioral health among vulnerable populations. So military veterans, with some colleagues at RAND, did worked on a study that involved Native American emerging adults, and did a paper on pain in that population. Also, got a lot of training in methodology, so primarily like quantitative and computational data science methods, things like that. So, now, like I said, I've been an assistant professor at NYU for a couple of years now. My focus kind of remains on this intersection between chronic pain and behavioral health among vulnerable populations, kind of broadly. Also the application of methodologies like data science, as well as technology-based tools for intervening on these problems. And as we'll kind of talk about in this talk, I'm hoping to move towards interventions that kind of leverage methodology and target these conditions in more tailored and scalable ways. So currently, just starting the K12, and I've done some work in the past research-wise with emerging adults, and also, like I said, I really kind of enjoyed working with emerging adults as a clinician in the pain clinic, but I'd like to kind of pivot to more concretely kind of focus on them as a population as a researcher. And so, one of the reasons being, maybe people in this room would appreciate this, but I think kind of out there in the world, people don't appreciate how prevalent chronic pain is among emerging adults, right? Millions of emerging adults in the US. And, many treatments are designed with kind of heterogeneous, middle-aged or above samples, right? And they're in formats, behavioral health interventions. It's like 8 to 12 sessions that are 60 minutes. It's tougher to deliver those with fidelity in the places where a lot of people actually receive care, so like in primary care. And so I'd like to kind of address that gap as a K12 scholar, and sort of work towards behavioral health interventions that are kind of tailored and scalable and optimized, both for this population and in these care settings, without going into the methodological detail, given that things might, change and stuff. But so I was really, really attracted to the K12 program for a number of reasons. I mean, like I said, I have clinical experience with chronic pain. I'm really happy with the behavioral health research and methodological research training that I got in the past, but I've never, worked with pain mentors and gotten really robust training in the kind of the conceptual aspects of like doing, research on chronic pain. And so, certainly excited to work with a pain mentor and multiple pain mentors, and really, really especially also partnering with, people with lived experience. So a lot of my early work clinically was in the substance use field, and it's interesting. Like in that field, I feel like it's relatively kind of normal for people with lived experience to be kind of frontline practitioners. But then when you move onto the research side, it's sort of less common to have their voices be front and center. And so I really appreciate that this program seems to be flipping the script on that, at least for pain science. Also, looking forward to getting pilot data and the kind of foundation for an R01. So with that, nice to meet everybody. Open for questions. Looking forward to talking after too.
Hi, my question kind of goes back to the AYA involvement. How difficult do you find that it might be to recruit and get these people to open up about their chronic pain?
Yeah, so that's a great question, and one that I look forward to finding the answer to as I go out and try to recruit. But I do have a connection to a clinic in New York City that's essentially a primary care clinic for emerging adults, and I have buy-in from the clinicians there to kind of try to recruit the patients there. And so obviously, it sort of remains to be seen like how easy or hard it is to get that buy-in. But I'm excited that I'm in a room of people that can kind of help guide me on, actually doing a decent job at that. It's gonna be important. So good question.
Hi, have you considered including narrative medicine modalities in your research at all?
Can you elaborate on what I've heard that term recently, and I feel like I want to say yes.
So it's so great that you have a history with working with veterans, because narrative medicine really works with that population set and people with chronic illnesses and chronic pain. So imagine, your doctor is basically not just looking at your diagnosis, but looking at your history. Where were you born? Who are your parents? What is your story? How did you grow up? How does living in Africa and then moving to America with sickle cell differ from living in Germany with sickle cell and moving to the UK? Like things like that. Like, how does your experience as a woman or a mother or a person that is a first child or only child with sickle cell? So just a holistic overview of the diagnostic criteria of the person as a person, but with their diagnosis. So I think that would be really great for you to look into, and we could talk about that as well.
Thank you so much. Yeah, one thing I didn't mention is I also really have gotten a lot out of qualitative methods in research, and I think the application of that to treatment, the way you're describing, sounds wonderful. So I look forward to talking to you more.
Yeah, great talk. I'm really interested in your science. I was curious, is there any way to gamify the therapies or just to make it fun in some way?
That's a great question. So the way I envision, and my kind of home mentor and I sort of planned this project out, is to use a methodology called the multi-phase optimization strategy. And so you sort of identify and tailor different components of intervention, and then can kind of see at this stage the feasibility of each one individually. And so that's I can kind of work in design features like that for individual components. And so yes, actually one thing we talked about is like, can we deliver in ways that are sort of more aligned, with technology and with the population? And so I think that's a really good idea. And I think I'm at time, so thanks a lot.
All right, thanks.
Well, good morning, everyone. It's really good to be here, and as Keith Richards would say, it's good to be anywhere. It's an honor to be here as an incoming K12 scholar, and I'm really glad to be a part of this year's cohort. For those of you whom I haven't met, my name is Justin Shepard. And I guess for those of you who I have met, my name is still the same. That doesn't change. I want to start off with the really important content first. You might be wondering who that little firecracker is in front of Blarney Castle there. That is my 15-month-old daughter, Madeline. We were over there for her first birthday. We were really there for a family member's wedding, but I'll let her know that it was for her first birthday celebration. I'll hold that from her till she's 18. A quick background about how I got here. As many of you probably know and experienced yourself, I am not exempt from a very long road to this K-12 program. I started out and got my bachelor's degree in psychology at the University of Massachusetts, Lowell, where I actually started out my college career as a music performance major. So I still play guitar pretty frequently. That's one of my fun hobbies. After that, I did a master's degree in clinical psychology at Rivier University before going to the University of Houston for my doctoral studies. And at the University of Houston, I was a NIDA F31 predoctoral fellow. And that project was sort of my first introduction to the intersection between pain research and addictive behavior. And that really looked at, I'm a tobacco and nicotine researcher by training. And that actually looked at folks who were Black Americans who smoked cigarettes and had chronic pain. And in particular, I was really interested in whether pain-related anxiety would contribute to relapse in a laboratory paradigm, and whether pain-related anxiety changed how folks smoked. So it actually measured smoking topography in the lab as well. I did my clinical training, my clinical internship at VA Boston, working in primary care behavioral health, where I did a lot of very brief, short-term cognitive behavioral therapy for chronic pain. I also worked in the behavioral medicine clinic too, running some smoking cessation groups where I, again, noticed clinically that a lot of these individuals who were trying to quit smoking also experienced some pretty substantial levels of pain and or chronic pain. And that was, really anecdotally, I noticed that it was impeding folks from maintaining long-term quit success at times. After completing my clinical internship, I stayed on at the University of Houston as a research assistant professor, where I serve as the co-director of the Research on Emotions, Substance Use Treatment Outcomes, Rehabilitation and Empowerment Lab, and I'm also the director of digital health there as well. So let's talk a little bit about research goals in the HEAL K12. Ultimately, I think as a lot of folks in this program, my goal is to build a independently funded research program at the intersection of pain and addictive behavior. And one strongly emerging area of my work is in the use of digital health tools. So things like ecological momentary assessment, just-in-time adaptive interventions that are integrated within digital therapeutics. And ultimately, the goal is to be able to really develop real-time personalized care. And then, through our lab's digital health initiative, I'm really working to translate that kind of research into interventions that are scalable, accessible, and really can reach people anywhere, anytime, where standard care may ultimately fall short. Which brings me to why I applied for the HEAL K12. So, this program, as you all know, really gives me the opportunity to train with folks who are leaders in pain science while continuing to work with my home mentor, Michael Zavlensky. And I think, just as much of that draw was the community of this program itself, and working with colleagues who are thinking about and seriously researching pain, learning from folks with lived experience, and working to build those skills that are necessary for a successful independent career in this space. So I don't want to get too far into the weeds on the actual project because we know that might change. But I'll give you sort of the general scope. So the starting point is that we know adults living with chronic pain often use tobacco or nicotine products at markedly higher rates than the general population. So I think recent estimates are about 11% in the general population. When you look at clinical pain populations, it's sometimes over 25%. And oftentimes, we hear that folks report using nicotine and tobacco as a means of coping with pain. Like many substances, nicotine's ultimately successful in the short term and provides some analgesic benefits, but we also know about the long-term health-related consequences of using nicotine and tobacco products as well. And so the idea behind my K12 project was, for folks who are interested in making a quit attempt who live with chronic pain or chronic overlapping pain conditions, how can we look at the day-to-day level in terms of how pain fluctuates during a quit attempt so that we can ultimately develop more personalized treatments to help folks sustain long-term quit success. So methodologically, the goal is to use EMA-based assessment and really just understand how these things interact on a day-to-day momentary basis in daily life. And, I think ultimately the primary goal is to inform more personalized smoking cessation interventions and really meet people where they are and where they are on a day-to-day basis in their quit attempt as well. So that's the general scope of my work, and I'm really looking forward to developing this further with the group. And thank you for having me here today.
Hi, my question is in regards to studying chronic pain and smoking. When the patient or the person being studied is trying to switch, so like use a nicotine patch or nicotine gum, how does that affect your study in the long term as a result?
That's a really good question, and it's one that I actually hope to answer in this project. So we'll encourage folks to engage in a quit attempt and actually provide them with nicotine replacement therapy throughout that quit attempt. And so the idea is that pain sensitivity may increase in the moment during that quit attempt, and we'll see if NRT does anything to modulate that increase in pain during that time. It's a really good question. I don't have an answer for you yet.
And then my follow-up to that is in regards to chronic pain and using EMT to treat this, what if that doesn't work? Let's just say, for instance, would you be open to using alternative treatments, holistic treatments, stuff like that?
Yeah, so just to clarify, thank you for your question. So EMA is a way of actually collecting the data on a momentary basis, so multiple times throughout the day to really understand how these things are working together. And so the goal is to have some answers to how these things are working so that we can then improve on existing treatments or develop more tailored treatments in the long run. Thank you for your question.
How are you going to address the digital divide, and particularly when it comes down to the rural areas?
Yeah.
And lower economic areas that don't have a smartphone or.
Yeah, it's a great question. There's certainly a gap when we're targeting rural and medically underserved regions in terms of technology and accessibility. We do know that on the whole that upwards of 95% of the population do own smartphones currently. Allegedly, that's what data shows. I hear you. And so I don't know. I think that's a question that's really open for discussion, and I'd love to hear folks' feedbacks about how we can navigate that issue. And I forget the first part of your question, Tom. I'm sorry. Yeah, and so the goal is to really leverage national-based recruitment, and so that's, I think, where the digital piece comes in terms of accessibility, but there's still obviously limitations there, as you pointed out. Thank you.
Hello. And then additionally with, I see that you have chronic pain and smoking. So with digital therapies, are you also providing alternative therapies in the real time while they're, so for instance, you said they might, for a stop attempts for nicotine patch.
Sure.
Is there any other alternatives that you're offering to help with attempt at like a holistic approach or anything like that? And then also my second question would just be, with chronic pain, do you know of any other diagnoses that you're specifically looking at within your target population, or is it just specifically chronic pain as a coverall?
Yeah, no, great question. So I'll start with the second one. So really, this is targeted towards folks with any chronic overlapping pain condition, so that we're not trying to be a little bit more inclusive of folks who are recruited for this project. And then there are actually no behavioral therapies that will be provided as a part of this. So it'll be a self-quit attempt, but there will be NRT provided for those who wish to use that. Thank you.
Yeah, I was just interested. So when you talk about nicotine, are you referring also to vaping?
Yes.
Okay. And then with your target population, are I guess when it comes to cigarette smoking, we know that older folks are still actually using a cigarette versus vaping.
Right.
And so I was just wondering how you're going to try to bridge the gap between an older population and those maybe who are vaping at the moment.
Yeah, great question. So there's sort of this, recently emerging trend called dual use. So for folks who maybe switch to using vaping in an attempt to quit combustible cigarette smoking, but actually continue to just use both of them. So I attempted to be pretty inclusive again in terms of recruitment criteria here, obviously up for some revision, but really wanting to recruit folks who are both using combustible cigarettes and or are using vape products as well. Thank you for your question. Awesome. Thanks all.
Good morning, everybody. My name is Han-Wei. It's really great to be here, and thank you for having me. And a great way to remember my name is to vote the right way, vote the Han-Wei. It was a slogan I used in high school a lot and was very successful, thankfully. So a little bit about myself. I grew up in North Jersey, right outside, about 30 minutes away from New York. We're known for our state diners and tax-free clothes shopping, as well as saying coffee and water. So after that, I decided to pursue my undergraduate and training at Northwestern University, which is not too far from here. And we're always dominated by University of Michigan football, and I am not bitter about that at all. But there, I was part of their BA MD program, so I was very lucky to have a guaranteed acceptance to medical school entering, so I got to explore a little bit beyond traditional sciences. I ended up doing a double major in biology and psychology with a minor in Chinese. And it was really during that time that I became very interested in kind of the biopsychosocial mechanisms behind human behavior, and kind of led me to where I am today. I also got introduced to research for the first time undergrad. At that time, I was doing basic science research in the Lurie Cancer Center at Northwestern, where I looked at sugar and glucose metabolism in cancer cells which was great. Learned to pipette a lot of things and play with gels, but I found that did not really spark as much joy as my postdoctoral colleagues, but I respect them a lot. So I said, thank you so much for the experience, and let's go to medical school. And so in medical school, that's where I really kind of opened myself to kind of learn about all the different aspects of medicine. And it was at that time I fell in love with pediatrics during my 30-year rotation that I decided to want to treat kiddos and adolescents for the rest of my life. And or in other words, actually, it was the one rotation I was able to wake up at the crack of dawn without a feeling of dread in my body. So that's the real reason. And it was also there I started to work on research more from the clinical side. So I had a wonderful mentor, Dr. Karen Sheehan. She was a pediatric ER doctor. And we started to look at pediatric injury prevention. And that was where we used large statewide databases to think about what are like characterizing current problem burdens and designing interventions to counter that. And that's what really sparked me to say, wow, research is really cool and it's beyond me pipetting and playing with gels. And that's where I got kind of my start in thinking about looking at current data and how we can build interventions to better the quality of lives for pediatrics and adolescents, young adults. It was also during this time that I kind of was doing all my rotations, and I decided to go into pediatric hematology oncology, or people with cancer and blood disorders, because it was during my inpatient rotation times that these children and their parents, they're just incredibly inspiring and incredibly motivating and incredibly humbling. And so if I could do a little something to make their cancer journey a little less, no pun intended, painful, then it was worth kind of investing my time and resources too. So given that, I decided to go into the pediatric residency, where I didn't go too far away from Northwestern. I was at University of Illinois at Chicago, and I was part of the accelerated research pathway. So I was able to cut down 1 year of my residency training and then add it to my fellowship. And that brought me to Memorial Sloan Kettering Cancer Center in New York City, where I did my training and treating kids with cancer and blood disorders. It was also during that time that I was part of a T32 program, training program there at MSK, that focused on symptom management and healthcare delivery. And that was where I met my primary mentor, Dr. Jun Mao, who unfortunately couldn't be here today, but sends his best. Where we focused on looking at symptom burden within adolescent young adult cancer patients. And by the National Cancer Institute, the AYA definition is anyone between the age of 15 to 39 at the time of diagnosis. And with that program, that's where we focused on recognizing, wow, there's a huge gap in pain management within cancer patients, particularly for adolescent young adults. Not only is there very little research, but there's very little interventions that are focused on this particular group in need. And that brought me here to the HEAL K12, which I'll share a little bit later about my project, but now I am currently an instructor. I just finished my fellowship in the Department of Pediatrics at MSK. So where I work is Memorial Sloan Kettering Cancer Center. Is one of the NCI designated cancer centers in New York City. We're located in the Upper East Side with additional sites in Long Island, New Jersey, and Westchester. One of the benefits of working at a designated cancer center is that MSK actually sees one of the largest volumes of pediatric cancers in the nation. So we see about 700 new patients a year, with more than 1,400 admission discharges each year. And particularly for the adolescent young adult patients, we see about more than 5,000 a year, which is a really rich cohort. So what I do now, where I see patients and conduct research, is I have my own pediatric oncology clinic where I follow patients long-term. I am the inpatient attending, and also we see kids in the pediatric ambulatory care center, which is the equivalent to like the ED, but in a designated cancer center. And you can see here, I love this picture of me and one of my patients here because, with permission, of course, posted with permission. He was actually one of my very first patients I picked up in fellowship. Diagnosed with acute myeloid leukemia, and I still see him, but he's a survivor now. And he's actually one of the reasons why I had thought about pain science too, because very early on, in oncology, oftentimes we have to jump to opiates very quickly for pain management because typical medications such as NSAIDs or things like Aleve, etc., can't be used because they impact the platelets in your blood, and a lot of the cancer treatments keep your platelets very low, so it's very dangerous. And so for him and his family had voiced to me very early, said, "Oh, Dr. Wu, we really can't do opioids. We have a history of abuse in our family, and we want to keep that as little as possible." And he's a bright young kid at the age of 18, 19 at that time. They're like, we need to do everything possible to not have that happen in addition to the cancer. And so that's where it brought me kind of to my current kind of research focus is looking at integrative medicine strategies to help opioid-sparing pain management in adolescent young adults with cancer. And so I see also consults, the integrative medicine patients in the pediatric AOA clinic, and I also assist in integrative medicine therapy sessions such as acupuncture. And I also wanted to share this picture down to the lower left here because research has also shown that dance therapy can be very effective for young patients who are experiencing pain. And this particular patient, she is a patient diagnosed with neuroblastoma, which is a solid tumor of the adrenal glands that's seen in very young patients. And they are treated with an antibody regimen called naxitamab or dinutuximab, which basically has some like nerve cell targets too. And so they have a lot of pain in their feet. And so actually they found that with like structured therapy with integrated medicine such as dance therapy, they're able to kind of reduce the burden. And so it's really those type of ideas that really sparks my interest and want to dive further in this field. And so for my research and career goals, my goal is to become an independent clinician scientist focused on integrative, non-pharmacologic or non-drug pain management in AOA cancer. The research goal is to develop, test, and implement evidence-based interventions that improve outcomes and reduce opioid reliance. And a long-term impact I hope to have is to really inform clinical practice and improve pain care for this underserved population. So in terms of the area planned K12 research is to really develop and test an integrative non-opioid pain management strategies for AOA cancer. The focus of my aims will be to characterizing the current pain burden in AOA cancer, their healthcare utilization associated with this uncontrolled pain, and their access to integrated medicine such as acupuncture and massage, which are evidence-based integrated medicine strategies that have been shown to reduce cancer-related pain in older adults. So we'll be using retrospective EHR data and also stakeholder interviews to identify risk factors, utilization patterns, and barriers to care. And with this information, I aim to develop a stakeholder-informed, patient-centered integrated pain intervention for future pilot testing. And so what drew me to the HEAL K12 program was that it's a very specialized training in pain science to complement my oncology background, provides predicted time and mentorship, both from my home institution and also on a national scale. I actually just met Laura Simmons today, who is my assigned pain mentor, which was great to support my transition to independence, along with methods training to design patient-centered AOA pain interventions. And one of the really important things to me is building this national collaboration network to build multi-site research partnerships. And that's particularly important in pediatric and AOA research because oftentimes single center studies are not enough to power strong clinical trials. So you really need the multi-center aspect, particularly for pediatric and AOA research. So I'm really excited to get to know everybody. I would love to keep in contact, have a collaborative kind of mindset going forward. So outside of being a nerd, I like to do things with my hands. So I've done pottery, I've tried glass blowing, and in the picture down in the right-hand corner, I've been able to make like those little temple amulets in Japan using like their traditional weave, which I think is really cool. So maybe I am an adolescent at heart because I think a lot of the patients I talk to, they've always talked to me about like creative things, and really that's what, when I'm on vacation, I try to do one activity that kind of like involves me doing something with my hands. When time allows, I do like to try like different activities that are like known to that area. So here are pictures of me doing snorkeling and surfing in Hawaii. I fell down so many times on that board, I can't even count, but it was a great experience. And then here's me with my parents. I dragged them at the crack of dawn to go to Diamond Head State Park to climb the volcanoes. And then they hated me for it, but it was okay because we got great views at the end. We are wearing sunglasses to mask our internal pain of waking up so early. And then the center is I love to eat. I love whenever I go to somewhere, I really like to like explore the local cuisine, etc. So this was me when I was in Taipei. So I just posted a picture of like all the food I ate, and that was kind of my summary of my journey. And I joked that I like to work out just so that I could eat more wherever I go. So thank you so much. Here's my contact info, and I would love to like talk to everyone.
Hi, I'm Rebecca. I was talking with Sydney briefly at breakfast earlier about sort of the difficulties of pulling, especially like pain scores out of EHR. So, what kinds of things are you doing to sort of mitigate or that difficulty?
Mm-hmm. So one of the things at my home institution that we do is that before every clinical visit, it's not required, but patients are asked to fill out kind of a survey, and part of that survey has like a very brief what they call PEG score, which is the combination. It's like a short, brief, abbreviated version of the brief pain inventory, patient reported. So we'll ask questions such as, what is your pain now? What's your pain in the past week? And then how has this influenced your day-to-day life? It's not perfect, and it's actually one of the limitations of my study because it's very patient-driven and the time points are very erratic in a way. But what the hope is that in a more research-ready setting, that we can advocate for like timed assessments, pain assessments, both from the patient-reported aspect, but also from the clinician-reported aspect to see what their pain scores are at controlled times so that we can track that over time for patient care.
I also think it would be interesting to, in addition to that, include some measure that looks at quality of life, to try to parse out also, if the pain scores are increasing or decreasing, could that be due to less social isolation or all the kinds of factors?
Yeah, and that's an excellent point, and that's something that I've been thinking about with my mentors too as well, because my experience with adolescent adults is oftentimes these surveys can be very, very long, and the last thing we want to do is create more survey burden on top of a new cancer diagnosis, on top of cancer treatment. And so it's finding that right balance, but I'm very excited to work with my personal experience mentor as well as my title to figure that out too.
Hello, thank you. So I'm curious, using EHR, how well is it characterized what other non-pharmacological approaches they may use outside of maybe prescribed medicine? Like you mentioned massage. I was curious, like how often is that documented if someone is seeking that on their own, or if they just went and bought a TENS unit and are using that at home, or those kinds of things? How well or do you think you'll be able to capture some of those?
So we've kind of used in our EHR like the proxy, as close as we can to it. So right now it's like not only is a consult order placed, but there's also a licensed integrated medicine practitioner that documents that visit. It's not pretty data. I'll tell you, a very large portion of my K12 being able to be like cleaning that data, but that's the proxy we have. So we have that for massage and acupuncture. The specific part, ideally we would want to capture it long term, so like multiple sessions over time. For my K12, we're looking at the early post-diagnosis period, so it's like within the 6 months. So we're trying to capture within, hopefully by setting in a specific time window, we can capture more, be like within this time on X amount of sessions and what happened. But that's a point hopefully that we can capture on in the future. And then it has to also do with training the practitioners to document the right way. So that's the best proxy we have so far. Hopefully, we recently switched to Epic, which is the new system. So that's also another pain point, no pun intended again, to like figure out as well. Yeah.
Hi, Hi, that was a wonderful presentation, and so excited that you're getting into this field. Much needed. One question you sort of answered a little bit in terms of the time course of when you're assessing pain, because kids in treatment with cancer, the phases that you catch them in the induction versus the escalation and the maintenance phases, there are so many different types of pain they experience, from the procedure-related pain to the mucositis, chemotherapy-induced. I mean, there's so many different things. So do you have a specific type of pain that you are thinking about addressing with these integrative approaches, or is it just pain in general?
So that's a great question. Thank you. And is that something that I actually thought about very intentionally with my mentor to when I created this proposal? Because from a physician standpoint, I'm like, all of this pain should be addressed. Like, doesn't matter what it is, right? But from a researcher perspective, you have to be very targeted in the time frame and in the procedures and then covariates, et cetera. So for this particular proposal, we're looking for cancer-related pain, like directly related to like their disease. So that's why for me, I tried to limit it within the first 6 months of diagnosis. Granted, they'll be going through certain procedures, chemotherapy. So we had that pulled in as covariates right now to kind of adjust for late in our analyses. But right now, the reason I want to target early post-diagnosis is because that would be the proxy closest to like really just the cancer causing pain, not because of procedures, et cetera. Of course, with any cancer diagnosis, depending on what the cancer diagnosis is, there might be like upfront surgery, et cetera, debulking surgery, or even line placement can be very painful for younger kids or adolescent adults. So I've pulled that information as well. It's not gonna be perfect, but something that I can like at least talk about in kind of the research I do, like the work I'll produce. But in the future, if this goes well for the modalities, we could tailor almost the integrated strategy specific to a certain type of pain. So for procedural type pain, for example, even for younger kids, like something hypnotherapy could work well, mindfulness, right? And so in that study cohort, we would focus on that kind of patient population. For cancer survivors, there's also different types, right? For cancer survivors, because or at least let me define that more clearly. Cancer survivors who are finished with treatment, because technically cancer survivors from day of treatment, cancer diagnosis. So cancer survivors who has completed treatment, if their mobility is there, then we can talk about pain in terms of like, neuropathic pain, residual from treatment, or even for breast cancer survivors, oftentimes they're on like tamoxifen that have or hormonal drugs that have like joint-related pain, then we can target like yoga, et cetera. But for early post-diagnosis pain, I think the idea is to figure out what are the mechanisms causing this and then tailoring it directly to here. The reason we chose acupuncture as massage, because in larger clinical trials actually run by my current mentor in patients with advanced cancer, those are the two that have been evidence-based to show clinical efficacy. So that's why I chose those two modalities first for now.
Oh, my bad. I should know about this thing. I just wanted to say thank you so much for your talk today. Your multi-use of holistic approaches is amazing. I don't hear enough about it, so this is exactly what I love to hear when coming to these different events. You also minored in Chinese, so I wanted to ask, did you ever see any studies in, the differences in Western medicine versus, the medicine that you in your culture and, in that studies that you had there?
So a lot of the bases, so I don't think I've done enough of a literature search personally for me to really dive into that, but I know the basis of integrated medicine is combining the Eastern and Western approaches to kind of complement current therapies, right? I will never tell a patient, you should not get chemotherapy, only get this, right? That's just not, it's always in complement to it, in adjunct to it. I think that's one of the biggest misconceptions of integrated medicine. So I think that's one of the things we're trying to put out there, being like, has to be evidence-based. And I love your comment about the holistic approach, because there's a shift toward cancer care as a whole person health initiative, because I think traditionally a lot of it's very cancer focused, like treat the patient, get the tumor out, go, right? But there's a lot that we need to understand, particularly for adolescent adults and pediatrics, where they're going through these different development stages to capture the biopsychosocial mechanism around it as well. So I think that's, I don't want to say that's like an Eastern mindset. I think that's just like a whole world mindset, I would like to say, to really focus on the individual, not defined by cancer, but them as an individual, and treating their aspects holistically throughout their cancer journey.
Thank you, Han-Wei.